you, ma'am, for the kind introduction. I'll be dealing with the shifting paradigms of medical treatment in POK. I have no financial interest, and I thank Dr. Yogita Gupta for providing me with some of the slides. So the overview of this presentation would be medical management of POK, which can be a local therapy as well as a systemic management. And management includes mainly steroids as well as immunosuppressants, newer modalities like biological therapy and other newer treatments. So before going into the newer modalities and the paradigm shifts, I'll like to talk upon the classical treatment, medical therapy, which is being, just a second. Okay, thank you. So classical therapy and the goals of treatment. The main goals of treatment would be to promote the epithelial healing and halt further progression of the stromal lysis, which is being caused by the inflammation, as well as prevent secondary infections. And prompt treatment reduces mortality as well as the ocular morbidity associated with PUKs. So clinical situations can be either an infectious pathology or a non-infectious pathology, and differentiating these with the investigation as well as clinical examination is very pertinent. So first would be a non-infectious cause, which can be associated with systemic immunological diseases and collagen vascular diseases, or if you can't find any cause for this, you will label it as Moran's ulcer. On the other hand, you can have an infective pathology or with a secondary infectious upon an inflammatory pathology. So medical management should be cause specific, and having a tie-up with a rheumatologist is very important, because often you have to shift some of the biological therapy, or you have to titrate the dose of the medicines, or due to side effects you will have to stop the medications. So having a rheumatological referral is very important, and local therapy still holds a mainstay of treatment along with systemic treatments. And first, when you exclude the infective pathology or inflammatory pathology, you will have to add antimicrobial coverage to prevent secondary infections. So medical therapy of PUK in case of systemic autoimmune or collagen vascular disorders can be local therapy or systemic therapy. So copious lubricants for epithelial healing is very important. You can halt the collagen lysis with collagen inhibitors either topically or systemically, and low dose antibiotics for preventing infection or treat infection. Topical steroids are the mainstay of treatment. You can add on adjuvant therapies like cyclosporin. Systemic therapy includes corticosteroids, prevents stromal lysis with oral tetracycline, or disease-specific immunomodulators, vitamin C for healing, as well as systemic infection should be treated. So this is the overview of treatment in cases of PUK. And aggressive immunosuppression is very important in cases of aggressive cases or recurrent cases. And as I said, rheumatological consultation is very important. In cases of infection, if you suspect an infectious cause of PUK, corneal scraping should be taken, and empirical antibiotic, either fortified antibiotics or on monotherapy can be started. And depending upon the size of the ulcer, you titrate the dose. Culture positive, as in case of any corneal ulcer, which is an infective pathology, you treat according to the culture positivity or negativity. So I'll not be dealing much into this. Next is Moran ulcer. It needs a step ladder treatment protocol, where initially you start with topical steroids, then a surgical treatment of conjunctival recession, and then systemic immunosuppression or additional surgery and rehabilitation. So mainstay of treatment is topical steroids. It is required in cases of all immune inflammatory PUKs, and administer as per the severity of symptoms. If you feel that it is severe, then you give the steroids in a frequent dose. Initially, you can start with low potency steroids like a fluoromethalone or loteprednol if you think that the pathology is not severe or the symptoms and signs are not severe. In cases of rapid progression or severe cases, you can go for a higher potent steroids like a prednisolone phosphate or betamethasone. So usually it can be started QID or it can be started too early depending upon the severity of symptoms. Caution should be taken when you think of an infective pathology. You treat the infection first and then you start the steroids. Adverse effects can be corneal perforation, steroid-induced glaucoma, cataract, and susceptibility for secondary infections. Next, adjuvant therapy would be lubricants. As I said, copious lubricants should be given, which is preservative-free. And next would be a topical collagen inhibitors like acetylcysteine, 10 to 20% QID dose can be given to inhibit the collagen lysis and prevent further inflammation. And anti-glaucoma medications to control, often these has inflammation and causes the IOP rise. So it should be treated with anti-glaucoma medications to prevent perforation. And cycloplegics for symptomatic relief, and autologous serum drops can be used in case of severe epithelial defect. It enhances the healing of epithelium. So other systemic medications, topical medications like oral NSAIDs, systemic medications like oral NSAIDs, vitamin C, doxycycline can be used. And as I said, aggressive systemic immunosuppression and corticosteroids can reduce the morbidity. Systemic steroids can be useful in PUK with progressive thinning. Usually it is started at a dose of 1 to 1.5 milligram per kilogram at a maximum dose of 60 milligram per day per person. And intravenous methylprednisolone may be considered in cases of severe PUK with systemic causes, and monitoring of adverse effects should be done. So choice of therapy should be tailored depending upon the symptoms. And first choice would be oral prednisolone in the initial phases, and then you shift to a second line therapy like a immunotherapy, methotrexate, azathioprine, cyclosporin, mycophenolate, or you go in for a higher ended newer biological agents in cases of severe or recurrent cases, or in case you want to keep it in a remission phase. So, which is the right immunological agent, how to follow up, what to choose, when to initiate immunological agents, all depends upon the patient's severity of symptoms, recurrence, or associated systemic diseases. So, this has to be a custom-made treatment depending upon the patient's presentation. In cases of underlying systemic autoimmune diseases, you can start with immunological agents along with steroids. Once the steroids take sets in action, the immunological agents will take a few weeks to start the action. So steroid should be the initial mode of treatment in all cases. And which immunological agent to choose depends on the underlying, as I said, underlying diseases, disease severity, as well as the side effect profile. What are the immunological agents which you can use? Either you can use a topical immunomodulator or a systemic one. Topical ones are the topical cyclosporins like calcineurin inhibitors, or topical tacrolimus 0.03%. Systemic immunosuppressive agents may be methotrexate, cyclophosphamide, mycophenolate, mofetil, azathioprine, or cyclosporin A. So these has to be chosen depending upon the cause of cause of PUK. Is it vaginous granulomatosis, is it rheumatoid arthritis, or depending upon the tolerance of the patient, side effect profile of the patient. Methotrexate, a little bit on the different types of immunomodulatory agents. Methotrexate is an apoptosis inhibitor of T cells, and it can be given in a dosage of once in a dose, 5 to 25 milligram per week, and tapered over a duration of 12 weeks. All these agents can be tapered over a period of 12 weeks depending upon the response. And side effects includes hepatotoxicity, leukopenia, ulcerative stomatitis, nausea, fatigue, renal failure. Next is mycophenolate, which is lesser of side effects. It is an inhibitor of T as well as B cells. It is started at a dose of 1 to 3 gram per day, and tapered, as I said, over a 12 weeks period. The major side effects are elevated LFT, GI upset, as well as bone marrow suppression. Next is cyclosporin. It inhibits the T cell activity, which is a calcineurin inhibitor. 2 to 3 divided doses can be given at 2.5 to 5 milligram per day per kilogram, and tapered as required. Most common side effects are gum hyperplasia, hirsutism, and hyperkalemia. Next is acetoprin, which is a DNA synthesis inhibitor, and it is given at a dose of 1 to 2.5 milligram OD or BD doses. Side effects include skin rashes, predisposition to neoplasias. Cyclophosphamide, it is also an inhibitor of T cells, which is an alkylating agent, and single dose of 2 milligram per kilogram per day can be given. Side effects are bone marrow suppression, as well as other common side effects like nausea, vomiting, diarrhea. So this is a whole list of immunomodulatory agents which you can use with the dosage as well as the specific side effects. So how do you follow up these patients? These can be followed up depending upon the severity of symptoms. If you think that the patient has a severe symptom, you call the patient very frequently and assess the response weekly or after 3 days if the patient has an impending perforation. And on follow-up, you have to investigate and look for the systemic side effects with complete blood examination, LFT, RFT, as well as ESR and CRP, and chest X-ray to rule out infections. ESR and CRP will guide us to titrate the dosage of the drugs, whether the inflammatory pathology is being under control or not. The other blood counts, LFT, and kidney function tests are just to look at the side effects which is being imparted from the immunological agents. And so, as I said, this is the newer modality of treatment where biological therapy is being used. Anti-TNF alpha inhibitors like rituximab, infliximab, anti-IL agents, B-cell inhibitors, antibodies with specific targets, as well as immunoglobulins intravenously can be given. Infliximab is given in a dose of 3 milligram per kilogram. So side effects are infections, drug-induced lupus erythematosus. Next is etanercept, rituximab, adalimumab. Etanercept is a TNF alpha inhibitor. Rituximab is an anti-CD20 inhibitor antibody, and adalimumab is a TNF inhibitor, monoclonal antibody. So all these can cause serious infections and activate hepatitis B, dormant, tuberculosis, all these things. So you have to rule out infections prior to starting the treatment as well as during the treatment course. Or interferon alpha 2b can be given in cases of Morin ulcer with hepatitis C infection. So these are some more newer biological agents: obinutuzumab, golimumab, tocilizumab, belimumab, abaccept, and JAK inhibitors like tofasitinib can be used. So all these agents can be chosen in coordination with a rheumatologist. So they will be able to titrate the doses, monitor along with the clinical follow-up which is being done by ophthalmologist. So which therapy should be chosen, biological therapy or immunosuppressants? In the remission phase, it is recommended to start with an immunosuppressive agents like the steroids and other agents like methotrexate, cyclophosphamide and all. In the maintenance phase, you have to shift to a biological agents because it is a longer or a chronic phase where the side effect profile should be reduced. So newer biological agents will have a lesser of side effects which can be used for a longer duration and control the cause of POK or the inflammatory pathology without much side effects. So that finishes my talk. Thank you, everyone.